What is non-radiographic spondyloarthropathy? Hello, this is Dr. Tambar from Chicago Arthritis and Regenerative Medicine. Somebody asked me a question on social media. They have back pain, they tested positive for HLA-B27, but their imaging is negative and their doctor says they don't have ankylosing spondylitis. What should they do? One of the more confusing situations I see in clinic is when somebody tests positive for a genetic marker called HLA-B27, but their imaging is normal and their doctor tells them they probably don't have ankylosing spondylitis. So what does that mean? Let's walk through exactly what the HLA-B27 test means, how we diagnose ankylosing spondylitis, and how we manage a similar condition called non-radiographic spondyloarthropathy. HLA-B27 is a genetic marker found in about 6 to 8% of the general population. Alone, it does not mean you have a disease, but it does increase your risk for certain autoimmune and inflammatory conditions, most notably ankylosing spondylitis. Ankylosing spondylitis, or AS, is a form of inflammatory arthritis that mainly affects the spine and sacroiliac joints. An individual's immune system is overly active, miscommunicating, and attacking their own joints. This condition often begins in young adulthood, late teens to 30s. Symptoms include chronic low back pain, prominent morning stiffness for over an hour, pains that are worse with rest, and improve with activity. What makes it different from regular back pain? Well, degenerative or mechanical back pain usually gets worse with movement and better with rest. In ankylosing spondylitis, it's the opposite. It's worse with rest and better with activity. Spondyloarthropathy is the umbrella term for a group of related inflammatory conditions. These include ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory arthritis related to inflammatory bowel diseases. They often involve inflammation affecting the spine, the entheses, this is where the tendons and ligaments attach into the bone, and can sometimes cause inflammation in the eyes, skin, or gut as well. So how do we diagnose ankylosing spondylitis? It's not just based on a blood test. Diagnosis is based on a clinical puzzle made of the following. Symptoms to begin with. You should have significant lower back pain, significant stiffness first thing in the morning, symptoms that are better with movement, and worse in the morning or overnight as you're resting. On examination, classically, you'll find tenderness in the sacroiliac joints. Those are the joints in the very lowest part of the spine that basically connect the hips to the pelvis. You'll also have reduced spinal mobility as well. On imaging, classically in ankylosing spondylitis, either X-rays or MRI of the sacroiliac joints will show inflammatory findings. MRI is especially helpful early on when X-rays may look normal because they will show inflammation in the SI joints. When it comes to labs, the HLA-B27 test is supportive. It's not diagnostic, but it is suggestive that you are at risk for ankylosing spondylitis. Inflammatory markers like the CRP or SED rate may in some people also be elevated. It's important to note that you can have ankylosing spondylitis even with normal labs and imaging early in the disease. So what is non-radiographic spondyloarthropathy? This is a form of ankylosing spondylitis without the obvious damage on X-rays or inflammation in the SI joints on MRI. Patients have the exact same kind of symptoms, stiffness, pain, and fatigue. Many people with non-radiographic spondyloarthropathy will eventually develop the imaging findings of ankylosing spondylitis, but not everybody will. So if your MRI is negative and X-rays are negative, you could still be diagnosed with non-radiographic spondyloarthropathy if you have the following. If you're HLA-B27 positive and you have 2 or more other classic findings of spondyloarthropathy, such as inflammatory back pain, meaning the very prominent morning stiffness and the very prominent symptoms that are worse with rest, and if you have other signs of inflammatory arthritis, such as inflammation in the peripheral joints, arms or legs, tendons or ligaments, that you can classically see on examination or ultrasound. You may also have uveitis or inflammation in the eye, psoriasis, which is inflammation in the skin, or Crohn's disease or ulcerative colitis, which is inflammation in the gut. And if you've had a positive response to anti-inflammatory medications, if there's a family history of ankylosing spondylitis, and if there's other markers of inflammation in your blood tests as well. The keys here are that you have other objective clinical findings that are very suspicious for inflammatory arthritis. So what is the treatment for non-radiographic spondyloarthropathy? We treat based on the severity of symptoms and risk of progression, not just on your imaging results. Conservative first-line options should include regular exercise and movement, and working with physical therapy if needed, an anti-inflammatory diet and gut health support, and anti-inflammatory supplements like omega-3s and curcumin. Some over-the-counter medications like anti-inflammatory medications can be helpful if you're having pain. And if symptoms are more severe or persistent, then utilizing stronger meds that work on the immune system. Some milder disease-modifying treatments like sulfasalazine can be helpful. In general, most folks with this diagnosis may need a biologic medication like a TNF inhibitor or an anti-IL-17 inhibitor. These may be appropriate even in non-radiographic spondyloarthropathy. The key principle here is that we treat inflammation early and aggressively if the risk of progression is high. So how would I approach this particular case clinically? Let's say you're my patient. Here's how I'd approach the situation. And again, as a reminder, this is someone who has back pain, HLA-B27 test positive, but their imaging is negative. So to begin with, I would want to do a detailed history and physical examination. Is the history and description of pain classic for inflammatory back pain? How much morning stiffness do they have? Are there any other signs of inflammation, such as eye inflammation, psoriasis, any gut issues? Besides the back, are there any other signs of joint inflammation as well on examination? Next, there's imaging. So there's mention by this individual that their imaging is negative. Does that just mean X-ray or MRI as well? If an MRI of the SI joints has not been checked, I would definitely check that to see if there's any inflammation in the SI joints. In addition, if there's any signs of inflammation in the peripheral joints, arms or legs, I would want to do an ultrasound to see if there's any other signs of inflammation, in particular in the tendons and ligaments where they attach into the bone. And then there's blood work. Inflammatory markers, I'd want to know if the SED rate or CRP are elevated. Again, that is suggestive of possible active inflammation. In this case, the HLA-B27 test was already checked and was positive. After that, I then also want to consider, are there any alternative diagnoses for why this person has pain? For example, do they have wear and tear arthritis or chronic instability? Or is there some other cause for their pain besides just inflammation? When it comes to treatment, in this kind of case, where imaging has been described as negative, you start with physical therapy, anti-inflammatory lifestyle changes, including nutrition and supplements, and on occasion, anti-inflammatory medications as needed. If symptoms persist and imaging or labs suggest inflammation, or your story is very convincing for inflammatory back pain, then we discuss biologic medications. In all cases, this is a shared decision-making process. We talk through risks and benefits of each treatment. We decide together based on your goals and symptoms, not just based on your lab results. Alternatively, if your clinical presentation seems less likely to be inflammatory back pain, and you fail conservative treatment, we then consider other options such as prolotherapy or platelet-rich plasma for treating instability or early degenerative back pain. The keys are to decide whether your condition is primarily an autoimmune condition causing total body inflammation and inflammation in the joints, or the cause is something else. To sum it up, testing positive for HLA-B27 does not automatically mean you have ankylosing spondylitis. But if your symptoms match and your story fits, we need to investigate further. Non-radiographic spondyloarthropathy is real and it's treatable. The key is catching inflammation early and using a personalized plan that fits your needs. If you found this helpful, please make sure to like, subscribe, and check out our website at chicagoarthritis.com for more expert advice on staying pain-free and healthy. Until we connect again, Have a good day and live well.